to present our results on experimental study about vasopressin and cardiogenic shock. First of all, severe acute myocardial infarction without early revascularization leads to acute heart failure and may be responsible for cardiogenic shock in 5 to 10%, but with a high mortality rate. The early increase of vasopressin in acute heart failure is associated with poor outcome, and copeptin is a biomarker of vasopressin secretion since they have the same precursor and is easier to assay and is available in clinical settings. The impairment of microcirculation during cardiogenic shock is linked to inflammatory response due to low blood flow and may be associated with organ failure and mortality, despite a good restoration of blood flow. The implication of vasopressin in microcirculation alteration remains unknown. So the goals of our study were to validate a post-ischemic cardiogenic shock experimental model with surgical left coronary artery ligation to obtain a left ventricle ejection fraction below 40%, susceptible to obtain a cardiogenic shock, to assess the involvement of vasopressin in the early phase of acute myocardial infarction. We explored the influence of in vivo treatment with a V1A receptor antagonist on in vivo tissue hypoperfusion and ex vivo contractile vascular response to vasopressin. Male Wistar rats were intravenously anesthesiated and randomly assigned to sham group with sternotomy and pericardectomy only, or ligation group with the same surgery and plus a left coronary artery ligation. Animals were treated or not with the antagonist of vasopressin by 3 perioperative intraperitoneal injections of the drug. We performed transthoracic echocardiography before and 24 hours after the surgery. Mesenteric oxygen saturation was measured by the NIRS technology using the INVOS device before, just after, and 24 hours after the surgery. Mean arterial pressure was measured by a carotid catheterization 24 hours after the surgery, and plasma lactate and copeptin levels were measured on blood samples. Animals were sacrificed at 24 hours after the surgery with an anatomical earth examination to determine the size of myocardial infarction. The contractile response to cumulative doses of phenylephrine, KCl, and vasopressin were evaluated on aortic rings by measuring variation of isometric tensions to obtain dose response curves. This is the flowcharts of the experimental plan. We obtained 4 groups of animals regarding ligation or not of the left coronary artery and the treatment of or not with vasopressin antagonist SR 49 or 59. We observed a trend for lower mortality rate after left coronary ligation in the group treated with the antagonist at D1. We exclude patients with a higher left ventricular ejection fraction, higher than 40%. We compared the preoperative characteristics of animals without perioperative treatment and animals who received a preoperative injection of the antagonist. There was no differences between them. To assess, to validate the choice of the thresholds of 40% for the ejection fraction, we observed a significant decrease of the mesenteric saturation at day 1 in this group, but not in animals with a higher ejection fraction, higher than 40%. 24 hours after the surgery, myocardial infarction animals were characterized by a lower mean arterial pressure, a lower cardiac output, and higher lactate level, and a lower mesenteric oxygen saturation. These differences was not significant in the group treated with the antagonist, but the number of animals was smaller. What is interesting to note is mesenteric oxygen saturation was significantly higher in this group than in the myocardial infarction group without treatment. Copeptin was increased in sham groups compared to control ones without surgery, with anesthesia but without surgery. Nevertheless, we observed an increase of copeptin level in acute myocardial infarction compared to sham with or without treatment with the antagonist. There was no difference between sham and sham SR groups, and we observed a trend for higher copeptin in acute myocardial infarction with antagonist, maybe due to a positive feedback after vasopressin stimulation and antagonization of the receptors. Mesenteric saturation decreased in all groups at the end of the surgery, and we observed a complete recovery at 24 hours after the surgery in sham and sham SR groups, and an intermediate but significant recovery in the AMI SR group, but absolutely no significant improvement of mesenteric saturation in the AMI group without treatment. 20% decrease of mesenteric saturation from baseline in acute myocardial infarction may indicate a severe tissue hypoperfusion partially prevented by antagonist administration. Concerning the vascular reactivity, we observed a decrease of maximal contractile response to vasopressin in acute myocardial infarction, indicating a reduction of available receptors following in vivo stimulation and internalization of the receptors. With the antagonist treatment, we observed a competitive profile between vasopressin and the antagonist, but the same response between sham SR and AMI SR was observed for the remaining 3 receptors which were not occupied. Sorry. To conclude, cardiogenic shock within the first 24 hours after myocardial infarction is associated with a high mortality rate and a prolonged decrease in mesenteric oxygenation. The reversion of these effects by antagonizing the V1A receptor suggests the implication of the vasopressin in the tissue hypoperfusion and maybe in mortality. The vasopressin secretion and release after acute myocardial infarction is confirmed by the higher copeptin level and the alteration of contractile response to vasopressin. These findings indicate critical role of vasopressin system in cardiogenic shock within the first 24 hours after myocardial infarction, and this role need to be explored in prolonged cardiogenic shock with a possible secondary deficiency. Thank you for your attention.
Okay, thank you. Thank you very much. A lot of information there. Very interesting. As far as I understood it, you gave the antagonist before you gave the infarction to the animal?
Yes. We gave the antagonist 1 hour before the anesthesia, before coronary ligation, and we give more injection 8 hours after, and 1 hour before the anesthesia of the next day before sacrifice.
So therefore, in sort of simulating real life, you wouldn't get there before the infarct. So, have you tried it where you begin after the infarct, like on recovery from the animal? Because
no, we don't know. We did it only to explore the role of vasopressin, but we don't know if it is useful in clinical settings. Of course, it's not.
Yeah. And my next question: the pharmacokinetics of your antagonist.
It stays a long time, a few hours. We need 3 injections to cover the 24 hours, but with an intraperitoneal injection, this molecule has a very high affinity to the receptor, and
but then did you, like in a control group, test vasopressin in a control group to see that you are getting blockade of the V1 receptor? Because
yes.
My question is, do you know you've got the right dose to block the receptor, and it's over your 8-hour intervals, it's still effective?
I'm not sure to understand, but in the ex vivo measurement...
not ex vivo, in vivo.
In
because
vivo also.
You want to see, have you given to a sham animal vasopressin with the receptor to show that you blunt the blood pressure response?
We don't give vasopressin, but in another step of the study, we give terlipressin to study the effect, because vasopressin is very short half-time. And
sure, but I'm just thinking
it's very, very hard to give to small animals like rats. It's so we give some terlipressin, and we observe the contrary effect. Yes.
And my final question, because obviously these animals have had heart surgery and then you've recovered them. Did they get any fluid? Because my guess is they won't be eating and drinking much. So
yes.
How do you know that a lot of your ejection fraction changes aren't related to hypovolemia?
Yes, we give, in the protocol, we give serum saline 1 hour after the surgery, intraperitoneal
anything
injection.
Else? Do they drink or anything? Because
and after waking up, they can drink as they want. And,
no, but do they?
And we measure the weight of the animals before the surgery and the day after. And all animals in sham and AMI groups decreased about 5 to 10% the weight. Yes, that's right. There is maybe a little bit of hypovolemia in these animals. This is a limit.
And they probably, with inflammation, it probably would have gone into extravascular spaces as well.
Yes, yes. Yeah. We after sacrifice, we observe a lot of animals with a lot of fluid effusion in the tissue. Yes, yes.
Please.
Thank you very much, Peter, for research. My question is, do you see a relationship between vasopressin, endogenous vasopressin and copeptine and systemic vascular resistance in cardiogenic shock in your experimental animals?
It's difficult. We tried to measure vasopressin directly, but it was very difficult and not very reliable. So copeptine is easier to dose. There was previous studies to correlate vasopressin with the copeptine level, but vasopressin is quite unstable, and copeptine remains high after a peak of vasopressin secretion. So it's easier to interpret. And vascular resistance is very difficult to assess because we have only measurement of cardiac output with echocardiography, and it's difficult to be sure this is the right, very accurate measure of cardiac output because of technical limits, and we don't have invasive measurement of cardiac output. So in these small animals, it's difficult.
Thank you very much indeed. Thank you.